Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Clinica Sierra Vista for hosting today's session, Seronegative Spondyloarthropathies, with Dr. Katherine Upchurch. Dr. Katherine Upchurch retired from the UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is professor of medicine at University of Massachusetts Medical School. Dr. Upchurch's abiding passions throughout her career has been the care of patients with all rheumatic diseases and medical education. She has been a leader in the Massachusetts Medical Society and the American College of Rheumatology and was selected in 2017 to be an ACR Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award, given to one area rheumatologist annually for excellence in arthritis care. And with that, it's all yours, Dr. Upchurch.
Hello, everybody. I don't know if you in particular have been on any of my former talks, but today's talk, entitled The Spondyloarthropathies, or alternatively the Seronegative Spondyloarthropathies, is basically an outgrowth of some of the other talks that we've had before, and some of what you learned before about how to approach patients will be used to build on your ability to do so in this particular very challenging group of patients. This is a case-based discussion, and basically, let's see, no disclosures. We are accredited, which is great, and I hope you'll get your forms in, because I really like the feedback, and my feelings won't be hurt. My skin is thick. I want you to tell me how I can do better, because the webinar format's a little bit different when you can't interact directly as you talk, which is the way I've done it for my entire career. The objectives of this talk are clearly stated here: to recognize the distinguishing features of seronegative spondyloarthropathies, also known as SPA, to differentiate these conditions from other common causes of back pain, and then, very importantly, to identify when early rheumatology referral is warranted. You see here a picture of someone with clearly inflamed bowels, inflammatory bowel disease. You see a schematic of the pelvis with the sacroiliac joint, which is where the sacrum interfaces with the ilium. And then you see another example of a knee, which is clearly voluminously swollen. And those are to tantalize you with some of the stuff that we're going to be talking about. I have lots of material, so I'm just going to go fast. There may be questions. In fact, I'd be surprised if there weren't. So please write them down, and be happy to talk at the end of the talk, or even engage with you after the talk at any time, via email, via text, etc. So I like case-based presentations, and this is a very terse one, but this is a real case that I had the opportunity to participate in, and it had a surprise ending. So TS, a patient I'd never seen before, 28-year-old white male with a history of hypertension, but he was otherwise healthy. And he was referred to the clinic with a 3-week history of left knee pain, warmth, and swelling. And that's all the history I'm going to give you. I'm going to give you about 10 seconds to think about what additional specific questions you might like to ask to try to begin your differential diagnostic evaluation. So really, it was more like 5 seconds, but I'm going to keep going. So basically, I would want to know, one, any recent trauma. Certainly, if you tear your ACL, you do have effusions. But this was a 3-week history, and there was no evidence of trauma. I'd want to know if there was any fever, constitutional symptoms, sweats, fatigue, weight loss, anything. Want to know if there's morning stiffness. Is he sexually active? Could this be gonococcal infection? Skin rash, any painful urination, diarrhea, any ocular complaints? Did he happen to have an altercation with a tick? Did he have a family history of back pain? And I went through all these, and it was no. And only when I questioned him, he gave a vague history of intermittent low back pain. never bad enough to think seriously about seeking medical attention. And we'll come back to TS later on, so stick with me because the ending is a surprise, was to me anyway. So on exam, he was afebrile. He had no rash, nail changes. He had a huge left knee effusion and no other findings. And notably, he had full painless flexion and extension of all of his spinous segments. Some routine labs showed a white count of 10,400, a SED rate of 54, a rheumatoid factor, and an anti-CCP, both of which were negative. And I aspirated his knee, and it showed 25,000 white cells per high-powered field, which falls into the inflammatory category, not highly suspicious for infection, with a predominance, but still only over half of the white cells were polys, not suggestive of a bacterial infection. Crystals were negative, and I did the exam myself, and cultures later returned negative for any organisms. So then at this point, we have to start really considering what could be the problem. So what diagnoses are you considering when you think about this patient? Now, we'll come back and we'll construct a differential diagnostic consideration after I've gone through the talk. And hopefully it'll build upon the blocks that you've already got under your belt from the previous lectures. So the spondyloarthropathies are listed here, and these are the group of diseases that typically are associated. The first, axial spondyloarthritis. Radiographic axial SPA is identified when you can see it on a plain film. And one of the recent developments in the last 5 years is the formalization of a second category called non-radiographic axial SPA. And this came with the recognition that a number of patients who had negative plain films had inflammatory changes on MRI that were consistent with sacroiliitis. Peripheral SPA is constituted by reactive arthritis, and these will be defined as we go along, enteropathic arthritis, psoriatic arthritis, the arthritis of inflammatory bowel disease, including Crohn's disease and ulcerative colitis, and juvenile ankylosing spondylitis, as well as undifferentiated spondyloarthropathies. Even though it says peripheral SPA, all of these have in common with axial SPA that there is an incidence of back pain, inflammatory back pain in all of these conditions. So some time ago, it's probably 10, 15 years ago when I gave a talk about spondyloarthropathies, at that time it was in vogue to lump all the diseases together, which I just did. And so the question is, why lump? Well, at that time, it was emphasized that these were simultaneously or sequentially identified in the same patient or in a family member. So, for example, there might be inflammatory bowel disease in your sister who had back pain and was identified to have spondylitis, or in your any other family member, or sequentially or even simultaneously in the same patient. The other thing is that there were many similar clinical characteristics among these diverse group of illnesses, whatever the diagnosis. So uveitis, enthesopathy, inflammatory bowel disease, sacroiliitis, post-infectious arthritis. As disparate as all of these seem, they actually are quite different, but they have many things in common. And the most predominant is the observation that they have a much higher than population incidence of HLA-B27, and now we know other genetic loci. And we'll learn more about that with further slides. Now, though, it turns out some 10 years after I spent much time thinking about it, it's more in vogue to think about the group of spondyloarthropathies in this way, with spondyloarthritis being a pervasive term, and it's now felt that axial spondyloarthritis is one leg, which is composed of the two that I've mentioned already, non-radiographic, that is, you can't see it on plain films. You have to get an MRI, and it has to be abnormal, or radiographic AS. And that is something you should know. I liberally often, I tried not to, but I do, have used the term AS, ankylosing spondylitis, to reflect the radiographically identifiable abnormal pelvic films that indicate sacroiliitis, fusion of the spine, et cetera, some other things that we'll learn about. So ankylosing spondylitis is the prototypic radiographic axial spondyloarthropathy. The other point is that now we recognize that there are peripheral spondyloarthropathies, and these are the group that were that long list below. They include psoriatic arthritis, IBD-associated arthritis, reactive arthritis. And what we'll learn as we go through this talk is that there are forms of these particular diseases, particularly involving psoriasis or inflammatory bowel disease, that are not associated with genetic predisposition to back pain or to ankylosing spondylitis. And we'll learn that those really don't share many features, but that there's a subset of patients with psoriatic arthritis or with inflammatory bowel disease associated arthritis that are basically just genetically predisposed to develop axial skeletal disease. And the genetic predisposition comes from the presence of HLA-B27 and other genes, which I'll emphasize a couple of times later on, in their genetic makeup. The same can be said of a condition called reactive arthritis, and also undifferentiated spondyloarthritis, where you just don't know quite yet what's going to happen. So let's talk about what axial spondyloarthritis really is. Axial refers to the pelvis, the spine, and some joints that are in the chest, such as the costochondral joints, as opposed to peripheral, which are the hinge joints that comprise most of the joints in the body. And this is a multi-system inflammatory disease characterized by inflammation of the axial skeleton, including the sacroiliac joints and the spine, with subsequent new bone formation. And we'll learn down the road that new bone formation is a late finding, but produces most of the functional disability. There are two forms, I said, either radiographic, and by the way, if I do repeat some of this stuff, I thought it was worth going over more than once. So this is intentional. I struggled with this talk, and I struggled with how to put it in a way that you would take away a message, you would understand the differential of these illnesses, and know where they fit in the broad scheme of things. Anyway, included, as I said, is either radiographic axial SPA or occult MRI identified non-radiographic axial SPA. There is a variable incidence among every single one of these conditions of extra-axial disease. Arthritis, enthesitis, uveitis, psoriasis, inflammatory bowel disease are included in the extra-axial disease. And as I said, commonly there is a genetic predisposition of HLA-B27 and other genes that collectively lead to the deranged response, probably we now know, to certain bacteria. Now, you've all probably heard that there are some disease associations, and if you notice the list on the left are the diseases that were on that list that I said made up the axial spondyloarthropathy group. So ankylosing spondylitis has a 90% incidence in white males. And by the way, the incidence of HLA-B27 varies based on the genetic population that it's associated with. So in a Caucasian male, there's a more than 90% incidence, if he has ankylosing spondylitis, of having an HLA-B27 positive. And if he has uveitis or aortitis, which rarely occurs, it can be as close to 100%. Now, reactive arthritis is the arthritis that occurs after somebody runs into one of a variety of bacterial infections, particularly Shigella, Salmonella, Yersinia. And this was previously known as Reiter's syndrome. The name has been universally changed because Reiter was a Nazi. And in keeping with many other discoveries that were named after Nazis, the name was eliminated, and now this is universally called reactive arthritis. So if you just have the arthritis, you have a 50 to 80% chance of having HLA-B27, but with sacroiliitis or uveitis, that goes up to 90%. We don't see children in our area, but there's an 80% incidence in this condition, juvenile SPA, and it can occur in childhood. And if you look at inflammatory bowel disease and you consider patients only with peripheral arthritis, there is no increased incidence of HLA-B27. But if you see patients who have axial skeletal disease, including in Crohn's disease or ulcerative colitis, there is a significant increased incidence of HLA-B27. And likewise, in psoriasis, if you have peripheral arthritis, which occurs in about 15% of patients with psoriasis, maybe a little bit more, those patients who do not have any axial symptoms or findings don't have an increased HLA-B27, whereas patients who do have a 50% likelihood of having HLA-B27. Now, HLA-B27, and I'm not going to go into the, I thought, very esoteric but fascinating research that's gone on, all the way down to sequencing the structure and doing all sorts of tantalizing things to try to understand this illness. But I wanted you to know that this is a type 1 major histocompatibility gene, and its prevalence in mid-European or Caucasian populations is about 6 to 8%, but there's a widespread difference in prevalence among American Indians, among Eskimos, among Asians. So many different populations have different presence of HLA-B27 throughout the entire population. Now, one thing that we'll talk about again briefly at the end of the talk is having an HLA-B27 gene does not, and I want to emphasize, does not mean that you will have or do have one of the spondyloarthropathies. It means just what it says, which is that you have a positive HLA-B27. And there's much more than just the presence of the gene that leads to disease. The function, though, of HLA-B27 is to present peptides to the immune system to defend the organism against microbes targeted by CD8 positive T cells. Now, if you are HLA-B27 positive, regardless of anything else, you have about a 1 to 2% lifetime chance of having disease. If you have a brother or a sister who has you're wondering about a risk of HLA related spondyloarthropathy, it is 82-fold higher than the general population. So that is the SPA risk in your brother or your sister. If you have ankylosing spondylitis and HLA-B27 positive, you have an 82 times greater chance than the general population of developing SPA. Now, I'm not going to spend any more time talking about the chemical aspects of HLA-B27, but there are some excellent references at the end of the talk that those of you who might be, I don't know, bored on a Friday night or something, you can pick them up through your library, and most of them are downloadable, and it's really quite interesting. A tremendous body of research has been done about this, which is the most closely associated genetic modification of normal genes of any that's associated with disease that's ever been defined. And it's led to just tons of research about what causes ankylosing spondylitis and related conditions. And to date, we still don't know for sure, but we know that HLA-B27 plays a major role. Now, the Assessment of Spondylitis International Society, ASAS, has determined that there was a need for criteria to basically, as other criteria, help researchers do research on specific diseases. So some of the studies that I reviewed said, no, these criteria are not diagnostic. But then somewhat begrudgingly, some of the others said, well, you can sort of use them diagnostically, and they've been validated, and we know the sensitivity and the specificity. So I thought I would go through these because it really provides the framework for the rest of my talk, and also helps you understand and reiterate the features, the SPA features, and understand how some of these are categorized with certainty. So let's say that you do have sacroiliitis on imaging. If you have one of these features with 82.9% sensitivity and 84.4% specificity, you can be said to have SPA. And those features include inflammatory back pain. Hold on, we'll come back to that. Arthritis, enthesitis, particularly of the heel, and that's insertion of tendons on bone. Uveitis, dactylitis, which is general inflammation of the tendon that runs up and down a bone, often of the toes. Psoriasis, Crohn's disease. If you have a good response despite one of these to NSAIDs, if you have a family history of SPA, and if you're defined to have an HLA-B27 that's positive or an elevated CRP. So you only need one of these features if you have sacroiliitis on imaging. And the high likelihood is that you will have one of these features, and you will safely be able and comfortably be able to be included in research groups of patients who have axial arthritis that's visible on X-ray, or ankylosing spondylitis. It's a little bit more tricky when you start with a patient who has HLA-B27 positivity. And remember, I said 6% of the normal uninvolved population have HLA-B27 positivity. So it's more stringent to be diagnosed with certainty to have SPA. You have to have either sacroiliitis on imaging, and that's either active inflammation or an MRI suggestive of sacroiliitis, or definite radiographic sacroiliitis. So this really is not all that helpful when you're considering people that have signs and symptoms of all these other diseases. But it is a way that patients can be slip in the back door and be diagnosed to have, say, ankylosing spondylitis, because the imaging basically confirms the diagnosis when you have a positive HLA-B27. Now, inflammatory back pain is kind of interesting. It's probably around a lot more often than we think. The average age of onset is less than 40 to 45, and sometimes it's late teens, early 20s. Inflammatory back pain is insidious. It's ubiquitously worse in the morning, and it also is associated with interrupted sleep. It improves with activity, and sometimes it's associated with fatigue, fever, weight loss. What we learned last week, last talk, and the one before, that we call constitutional complaints. Now, non-inflammatory back pain almost always happens after 45. It often occurs in an acute onset. It's best in the morning, worse with activity, and there are no associated constitutional symptoms. So these are pretty clear, definitive ways to separate back pain. But as usually is the case, sometimes you have patients who fall right in the middle, but you just have to be sure and ask the question and determine what you think in your mind is going on. Is it inflammatory or is it non-inflammatory? To be honest, I couldn't tell from talking with Todd, because he didn't really describe much in the way of back pain, and hadn't thought about it too much because it wasn't bothering him too much. Now, the epidemiology of ankylosing spondylitis is as follows. The onset often, as I said, is as early as the third decade, but it's almost always before age 40 to 45. Males are much greater than females. These are in image diagnosed that is X-ray diagnosed spondylitis, 2 to 3 to 1. But because physicians perhaps are more sensitive and MRI is much more sensitive, when you start using MRI instead of plain films, the incidence is approximately the same, male equal female. The prevalence of ankylosing spondylitis is 0.3 to 1.4%. This is highly influenced by the background HLA-B27 positivity. Now, the incidence rate is 7 per 100,000 per year. Y'all might remember that we talked about rheumatoid arthritis, and it turns out about 1% of the population have rheumatoid arthritis, and it's highly likely that you will see at some point, perhaps not every year, but at least every 2 to few years, somebody who does have axial SpA, and you may not know it. And you need to learn by thinking about these illnesses through talks like this and going back and reviewing this talk afterwards, how to respond and how to just have it on your radar. And that's the most important thing to think about, is have this on your radar. This discusses the difference between male and female. So females typically have a longer delay. They have more peripheral manifestations and less in the way of obvious manifestations such as back pain. By the way, they have less association with HLA-B27 positivity, which is another indication that there are obviously other genes involved. And they also have a higher, males have a higher proportion of HLA-B27 positivity. So when they are clinically expressed, they have more active disease, more functional impairment. This is the women. And they also have fatigue, pain, and sleep disturbance. Males have a higher level of C-reactive protein. And if you're able to measure IL-23, interleukin 23, or interleukin 17A, which is really experimental, those levels are actually higher in males than females as well. Females have a higher frequency of concomitant issues of depression and fibromyalgia. And this often basically clouds the diagnosis of axial SpA, because females, particularly 30s and early 40s, are overlooked, and their symptoms aren't as carefully considered because they are dismissed often as being those of depression, perhaps those of fibromyalgia. So this is my entreaty to listen to what the patient says, and don't dismiss any of their symptoms without a good reason to. Now, males have a higher frequency of cardiovascular risk factors, including hypertension, dyslipidemia. They do have, on occasion, higher risk of ischemic heart disease. And as far as women are concerned, as I said on the last slide, there's less radiographic damage when they present with back pain that's inflammatory. And so they are the ones who make up the larger proportion of the non-radiographic axial skeletal disease. And they also have slower, or a very relative lower rate of radiographic progression. In point of fact, males present with more radiographic damage, and they often present with extremely high and rapid radiographic progression in the face of months to years. And by the way, women don't respond as well to treatment, in particular NSAIDs, as men do. So these are just some interesting facts. Now, this is an example of a man who has ankylosing spondylitis, and you can see he presents, and this is the maximum that he can extend his spine, and this is the maximum that he can flex his spine. And so he can't ever get any closer to the wall from the upper segment of his body. And you can see his X-ray here. And what you see are the fact that this is fused anteriorly all the way up through the entire cervical spine. And this is the case, the advanced case of a man who's had this disease, perhaps unrecognized, perhaps recognized for many years, because this doesn't happen overnight. Now, I'm going to go through some of the radiographic findings. These vertical bony areas in between vertebral bodies are known as syndesmophytes. And the syndesmophytes are to be distinguished from osteophytes. An osteophyte always travels east-west before it goes north-south. So when you have a so-called DISH, which is diffuse interosseous skeletal hyperostosis, and that's one of the differentials that we'll see, that causes a stiff spine in men, particularly. They're these big flowing osteophytes, but these are tiny. They look very fragile, and you have to look for them. I mean, they're there if you know what you expect to see. And you can see there's a little one right here. And these, by the way, are the ones that are likely to be associated with fractures if you fall, and it's particularly disastrous, or can be, if the fracture occurs in the cervical spine and there's instability, because there can be cord compression, and this can lead to catastrophic problems. So, in addition to looking at the spine, in order to diagnose or to consider axial SPA, which is also, I've told you many times, called ankylosing spondylitis, we need to have an AP of the pelvis, just a plain AP of the pelvis. And what you can see here is two very abnormal looking sacroiliac joints. These should be very, very clean with no fuzziness. And I intended to put a slide in of a normal pelvis, and I'm sorry I didn't. But these are totally fuzzy, and you can barely make out the lines where the joints interface with the rest of the pelvis. And even here, you can see that there is some increased lucency that represents inflammatory change. And this indicates a fused sacroiliac joint. You can barely see the one on the right, whereas the one on the left is less likely to be fused, is less fused, but there's a little bit of erosive change here. So this patient, both are the same, or maybe they're different patients, but they've had sacroiliitis for a long time, but particularly in the D slide, the joint is almost effaced, it's gone. Now, the sacroiliac joint, as you know, is not a joint that often moves, can't move. There can be some fractures related to it or some other trauma that can lead to some mobility, but in general, it's not a mobile joint like the hips. And so this doesn't lead to any specific loss of motion, but it can be very painful. It's likely to be associated with the back pain that these patients experience, at least one reason. Now, when you do MRIs of a patient with sacroiliitis who has a normal appearing pelvic film, you often will see some changes of edema around the joint. Of edema around the joint. And you can see that on both sides. And you can see perhaps an early erosion here. And this is a non-radiographic axial SPA because the plain films were completely normal in this patient. So that's a good example of when the MRI leads to a diagnosis as opposed to plain films. What about the differential diagnosis of axial spondyloarthritis? Well, I've already mentioned what we call DISH, D-I-S-H, older symptoms and mechanical pain, not inflammatory pain. This is a very interesting condition to me. The ilium is the only side of the sacroiliac joint that is very, very condensed and looks sclerotic. And this is something that happens in people postpartum, and they're asymptomatic. And for some reason, if they get an X-ray, this can be identified. But it's not a problem. It's sclerosis of the ilium, maybe related to the trauma of childbirth. Hard to know, but it's just a condition. It doesn't really progress or cause any clinical symptoms. We've talked about degenerative spinal disease presents in elderly patients with mechanical symptoms. Fibromyalgia can be present when you have ankylosing spondylitis or not. But in general, this is not pain that's confined to the joint, and they don't patients with fibromyalgia don't complain of inflammatory disease. One thing that I've actually seen and that can be very confusing is sacroiliac joint infection or discitis. Patients with drug use get bacteremia, and the bacteremia ends up infecting a variety of different places, including the sacroiliac joints. So if there are risk factors like IV drug abuse, patients having undulating fevers, and the pain is very localized over the sacroiliac joint, including with provocative maneuvers, this is something you should suspect. Malignancy also can be confused with axial spondyloarthritis. And then very occasionally, trauma or falls can lead to severe pain from fractures. But this is atypical because the pain of ankylosing spondylitis is more subtle than a severe fracture. And usually there's a defining event. Now, we talked earlier about axial SPA, and I told you that if you looked at the big picture of the axial spondyloarthropathies, there was both axial spondyloarthropathy and peripheral SPA. And so this is the schematic of the ACEs criteria for peripheral SPA. So if you have arthritis, enthesitis, or dactylitis plus one of these, you can be said to have peripheral SPA, uveitis, psoriasis, Crohn's disease, preceding gut infection, particularly HLA-B27 or sacroiliitis on imaging. One of those plus any one of these can be defined as peripheral SPA. In contrast, if you have one of these, you have to have two of this leg. And these were done with computer algorithms looking at many patients to figure out basically what went in this box, what went in this box, to figure out the sensitivity and the specificity. So if you have one of these and two, arthritis, enthesitis, dactylitis, inflammatory back pain at any time in the past, or a family history, then you could be said to have peripheral SPA as well. And we'll understand a little bit more at the end of the talk why it's important to think about this diagnosis and also to think about the diagnosis of axial SPA as well. Okay, so what can I tell you? It's usually subacute in onset. The flares of the arthritis in particular are sustained or intermittent. Interestingly, the arthritis of peripheral SPA is oligoarticular. Oligo is a Latin word for few. So that means not very many joints. And this is very much in distinction from what hopefully you remember from my talk about rheumatoid arthritis, because rheumatoid arthritis almost never presents as oligoarticular arthritis. It's usually, rheumatoid arthritis is usually symmetric and polyarticular, whereas peripheral SPA arthritis is usually oligoarticular and asymmetric. Now, also, large joints are involved more frequently in certain groups of the peripheral SPA, particularly IBD. The knees and the hips are more likely to be involved. And in one subgroup of PSA, the distal small joints asymmetrically are involved, but that subgroup happens not to be one that's associated with HLA-B27. There is a group of patients with psoriasis who have large joint involvement, who have back pain and peripheral SPA. And so there are several different kinds of arthritis. And the purpose of this talk is not really to expand upon any one of these different peripheral SPA diseases, just to introduce you to this. Now, the peripheral SPA arthritis is not particularly responsive to NSAIDs, and rheumatoid factor and anti-CCP are negative. Okay, so now this is a little, shall we say, a tiptoe through the images. And this is, I have a funny story to tell you about this. I was telling the moderator at the beginning of the talk that one of the things that was particularly conspicuous when I was preparing this talk was that AI was everywhere. And so the way that AI learns what this is they ask people who view this slide to fill out a little box and to, in their own words, say what this is. And so when I read what they said this was, they said foot with fungal infection. And that was it. And that was wrong. And I was just totally too busy to figure out how to tell them that that was wrong and that it's not a fungal infection. Of course, that's in the differential, but this is not a fungal infection. Why do I know? Well, we see onycholysis, which you see a lot. That is separation of the nail from the underlying skin. And we see that in fungal infections, to be sure. But what we don't see is dactylitis. And I think it's pretty clear here that the entire structure of this fourth digit is inflamed, as is the third digit. And it's particularly striking when compared to the second digit, which has onycholysis, and so does the first. But the second digit itself is not involved with dactylitis. But I just thought that was really funny. So that's beware. Why do we get all this misinformation from AI? It's because they ask people who may not even be qualified to comment. Here's another example of onycholysis, and here you see some dactylitis, and you can see this fluffy sort of periostitis here, and here this little fluffy tuft. That's an example of the dactylitis. Now, I just wanted to remind you what a very large knee effusion looks like. It's uncommon to see something like this in a young person that is not, and that's associated with warmth, that doesn't end up having a specifically identifiable cause at some point along the way. This is the typical skin lesion that we see of psoriasis, and there are many other forms. There's guttate psoriasis, there's all sorts of different, but this is the characteristic extensor surfaces of the extremities that are involved with a papulosquamous eruption. So it's a very typical psoriatic skin rash. And also when we see pits, and this is a great example of these little bitty pits. It looks like somebody took the tip of a nail and went bang, 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 but didn't go through. And this is nail pitting that you see often with psoriasis and psoriatic disease. Now, I'm just going to take a little bit of a detour and review with you. And I would encourage you, because these are very small. I can barely read it with my glasses. So go back after this talk is over and just look at this slide, because there's tons of information. And this includes the distinguishing clinical, laboratory, and radiographic features of psoriatic arthritis. So psoriatic arthritis, polyarticular, common, same with oligoarticular, you can read as well as I. They have dactylitis, they have enthesitis, psoriasis. Rheumatoid factor only very occasionally is positive, and in that case, it's not related to the underlying diagnosis. Anti-CCP is not positive, and SED rate is usually only minimally abnormal. RA, all these things are in distinction to what I just went through with the psoriatic. Osteoarthritis, basically, we've learned by the last few lectures is rarely associated with inflammatory change. So most of the answers here are rare or no for any of the ones that I talked about. In contrast, ankylosing spondylitis has changes of axial spondyloarthritis, I would say 95 to 100% of the time. Occasionally has dactylitis, commonly has inflammation of tendons when they insert, such as the Achilles tendon. Occasionally, patients with psoriasis have ankylosing spondylitis. And basically, they do get nail dystrophy too, but rheumatoid factor is negative. So this distinguishes, and it should be when you think about it and you consider these patients and you step back and you look at the labs. Oh, there's something eating my cord over there. Anyway, when you step back and look at the lab, you should be able, and the x-rays, you should be able to sort this out. This is an example of enthesitis. This is a normal heel. And here's an erosion where the tendon, a big erosion, where the tendon inserts on bone. All right, I want to turn a little bit to the arthropathy of inflammatory bowel disease, but also make some comments just about the gut in general. Peripheral arthritis that occurs in genetically predisposed patients who are infected with certain type of bacterial gut infections. I've already mentioned once, it's called reactive arthritis. Reactive arthritis has a high incidence of inflammatory arthritis, and it is the entity that I told you was called Reiter syndrome. It also is associated with conjunctivitis, uveitis, and urethritis, genital infections as well. Now, if we turn to actual inflammatory arthritis in IBD, inflammatory bowel disease, the incidence is 7 to 25%. And the articular involvement can precede the actual onset of the diagnosis of IBD. So you can have a big swollen knee and show up without any abdominal complaints or back pain quite early, and then down the road be diagnosed to have inflammatory bowel disease. And then if you flip the coin and you ask, well, how many people with SPA eventually have inflammatory bowel disease? And the answer is not trivial. 6 to 13% go on to develop inflammatory bowel disease, especially Crohn's disease. So all these are just informative to tell you that these are closely interwoven in a web-like capacity, and it's very difficult to tease them apart. Now, the axial arthritis in IBD, it varies as far as asymptomatic sacroiliitis all the way to really inflammatory lower back pain that occurs in as often as 10%. And there is a group of asymptomatic patients with sacroiliitis, that's the non-radiographic axial arthritis, as many as 10 to 52%. And then, interestingly, there's a 50% incidence of characteristic inflammatory low back pain in the absence of radiographic findings in IBD. I find that to be very interesting. The arthritis is more prevalent in patients with large bowel disease than in those with small bowel disease. These figures have been derived from studies of large groups of patients with validated disease. Just summarizing the SPA and gut, if you do colonoscopies on patients in these groups, and I find this slide to be fascinating. So if you do colonoscopies on patients with ankylosing spondylitis, you're going to find asymptomatic GI inflammation in 60% of patients. In patients with enterogenic arthritis, that's these diarrheal infections, it can be as high as 90%. In urogenital reactive arthritis, it's lower, 20%. Undifferentiated SPA, which doesn't really have anything else going on but some back pain, 65%. And in psoriatic arthritis, particularly the pauciarticular and axial forms, as many as 80% will have abnormal colonoscopies. I just find that this is really fascinating to me. Now, this summarizes the type of arthritis that these patients can get: peripheral, axial, occult IBD, and other. And I just want to run very quickly. You can get pauciarticular or polyarticular. And pauciarticular coincides with relapses of IBD. Polyarticular is independent. It runs a course, and it is associated with uveitis, but no other extra articular symptoms. And this is a discussion of joint complications in inflammatory bowel disease. I circled this because this group are the ones that truly have axial arthritis, the arthralgia, ankylosing spondylitis, inflammatory back pain. This is a busy slide, but basically it just summarizes whether peripheral arthritis with IBD, when the arthritis occurs, and which joints are involved. And this is an example of anterior uveitis, which, as you remember, is one of the peripheral spondyloarthropathy diagnoses that can be helpful in terms of making that diagnosis. This is the schematic that tells you what's involved in anterior uveitis, and this is to be distinguished from posterior uveitis that has a completely different presentation and set of associated entities. When you see uveitis in SPA, it typically happens in older age, patients with longer duration, patients with a past history of Achilles tendonitis, dactylitis, psoriasis, patients who are HLA-B27 positive, but they are responsive to NSAID, so that's an encouraging thing. Now, I just wanted to mention reactive arthritis again in one other way, because as primary care physicians, you may see somebody who comes into your office who doesn't have a regular series of recurring appointments. He might just be a young person or female or male who either had developed seronegative asymmetric arthritis following, seronegative referring to rheumatoid factor, following an infectious diarrheal illness. And the infection, as I mentioned, chlamydia, Campylobacter, Yersinia, Salmonella, Shigella. Often these are associated with inflammatory eye disease, enthesopathy, oral ulcerations, a scaly rash on the bottom of the feet, and a rash on the distal aspect of the penis. If you see somebody who comes into your office, the temptation is not to necessarily do a thorough exam, but it's very important to do that. And it's very important to take a history about recent diarrheal illness or recent urethritis or cervicitis, because this is one of the hallmarks of reactive arthritis, which typically is self-limiting, but sometimes does require aggressive treatment. Okay, now I have run through tons and tons of information, and I really hope that you'll take the time, like I said, to look through this talk again if your head is spinning and you're thoroughly confused. But I just want to remind you again that they're currently the way we think about ankylosing spondylitis or axial arthritis is the fact that spondyloarthritis is up here. There's psoriatic arthritis, there's peripheral SPA, which is separate from axial SPA. So those are the two groups. And the proposed pathogenesis is extremely challenging. There are several different ones, causes or evolution of disease that's schematically defined on this chart. And in general, these patients have a genetic backdrop, and this includes not just HLA-B27, but other abnormal genes, the IL-23 receptor gene. This is an endoplasmic reticulum gene, and these, turns out, are quite active and do contribute to the genetic predisposition. And then if you have exogenous triggers, or so this is basically proposed, the triggers could be infection or even mechanical stress, or endogenous triggers, gut dysbiosis, loss of epithelial integrity. The result is the activation of an immune response, which not only includes an adaptive immune response, but now we know an innate immune response. And there's a lot of new evidence about this that has led to change in the treatment paradigms. And when all of these things come together, all of these things, you see clinical features. And those include sacroiliitis, spondylitis, enthesitis, arthritis, dactylitis, and extramusculoskeletal manifestations, such as uveitis. And then at the very end of all of this, you end up with structural damage. So you start with erosions, and then there is new bone formation. And this has led to some, to me, really interesting research and led to some therapeutic approaches as well. But the structural damage is the very tail end of this scheme. And let's get back with this in mind and with all of the information in mind that I've run through and get back to my original patient. So I didn't give you very much information. Basically, I told you that he had a large left knee effusion. And I saw him once, and my initial differential diagnosis was, well, this guy's got hypertension, and he must have the same thing that the other 98 patients I had in the last few years with a new knee effusion and hypertension had, which is gout. It certainly more commonly presents in the small joints of the feet, but it would not be at all out of the question to consider gout as the leading diagnosis. It was very confusing to me with 25,000 white cells, with a normal being less than 1,000. But out of 25,000 white cells, and that's a very robust response with polys, why didn't I see any crystals? And I didn't tell you, but his uric acid was also low. So that just didn't add up. I filed all that information, and back in the day, I didn't do much in the way of additional workup. I didn't get pelvic films. I didn't get an HLA-B27 because, by the way, it's only really been in the last 5 years that you were allowed to get an HLA-B27. It was sort of the anathema of labs that you should order, kind of like people sometimes say the ANA is, because people didn't know exactly how to assess it, and many people felt that it was associated with the diagnosis, and anybody with an HLA-B27 positive had a spondyloarthropathy. But now we know that's wrong. Nonetheless, I didn't get an HLA-B27 either. So I'm sitting in clinic, and I get a call from an emergency room in a small emergency room in a small town in central Massachusetts, saying they wanted to discuss one of my patients. And it turns out the patient they wanted to discuss was this patient. And he did not have a primary physician, and somehow or another, he told them my name. And basically what happened to him was he presented with an abscess, an abdominal abscess. I thought, that's interesting. So come to find that he ultimately was diagnosed to have Crohn's disease. And in retrospect, he was one of those patients that I mentioned in whom his Crohn's arthritis, which was his inflammatory knee arthritis, oligoarticular, asymmetric, was a manifestation before his Crohn's manifest as part of his peripheral SPA. This story does not have a happy ending. It was well before we knew the best way to treat Crohn's disease, and I didn't really even see him after he ultimately was diagnosed to have Crohn's. And that is that he had multiple surgeries to resect bowel that was intractably involved, or to correct or drain abscesses, multiple. We're talking in the range of 5 or 6. And he couldn't stand that, and he committed suicide. So it didn't have a happy ending, but it was a fascinating ending to me, and kind of provoked me to put this talk. One of the things that provoked me to put this talk together for you all to think about this group of illnesses. So practical implications for you. 1, have a high index of suspicion. If somebody has a pattern of illness that doesn't fit what you've learned, think about other possibilities like axial SPA. And if you do have a suspicion, what's the best way to screen? Take a targeted history. Go ahead and order an HLA-B27 CRP. Get a plain pelvic film. SI oblique views are the best. And then if you're still interested in that diagnosis, order SI joint MRIs, but you have to use a special protocol. Call the radiologist. They will know. There's a special AS protocol for imaging the SI joints. If the screening is negative or inconclusive, you can follow the patient. But from my perspective, when to refer to a rheumatologist is when you don't know what's wrong, or if you do know what's wrong. So I think in any case, somebody who presents with either positive or negative history to explain this undiagnosed knee effusion, it would be helpful to refer them to a rheumatologist, either just one-off or to have the rheumatologist help you as far as what goes next. And again, having a positive HLA-B27 raises interest, particularly if he has back pain or has other abnormal symptoms that are outlined for you in the ACEs peripheral SPA criteria. But it does not establish a diagnosis. This is an example of screening for axial SPA. And these are patients who had or were involved in a specific protocol screening for axial spondyloarthritis in patients with psoriasis, iritis, and colitis. And what you can see is that the incidence in patients with anterior uveitis was really uh, quite high. Um, the specificity was 100% in patients with an MRI, and the sensitivity was 55.3 and 66.7. So in this particular study, um, the incidence of back pain was associated with an incidence of um, axial SPA when all comers were screened who had these preliminary diagnoses. And so some patients, some physicians have gone to specific clinics like ophthalmology clinics or orthopedics clinics that specialize in back pain, or GI clinics or dermatology clinics to pick out patients that might be worthwhile for screening, just to try to encourage early diagnosis of this. And this article in Arthritis and Rheumatology is interesting to review about that. Now, here is the list of items that would make you suspect SPA. I'm not going to read them all because we talked about every single one of them, even if in a very brief fashion, and we went over some of them in more detail. But if any of these things come up in history, physical exam, or findings, family history, and response to NSAIDs, suspect SPA. I put this down just so you'll remember again what the difference is between inflammatory and non-inflammatory back pain. And you may say, well, why does it matter? Well, just as in the case of RA, we have this huge array now of many different kind of drugs to treat these patients, starting with NSAIDs, using more traditional DMARDs, not in ankylosing spondylitis, but in the peripheral arthritis, turning to the biologics, the traditional anti-TNFs. And this is actually the anti-IL-17, which is closely related to interleukin 23. There's a relationship between those two, and these drugs actually inhibit IL-17 and some of their associated molecules. And then this reflects the fact that there now we know is some involvement of the innate immune system, and the JAK kinase and inhibitors can be helpful too. Well, if you don't have the diagnosis, then you can't apply any of these agents. And what you'll end up with down the road is a guy who looks just like the person who's standing next to the cervical spine film who can't move his back. So the bottom line is it's really important to think about these diagnoses, and it's the company it keeps, plus findings on exam, plus abnormalities that will help you lead to the correct diagnosis. Now, these are the references, very up to date, and I just think you'll learn a lot if you can either review the talk again or review some of these references at your leisure. But it's an important area that you should know about. Okay, with that, just about 5 minutes late. Wow, that's pretty good. We'll open the floor for questions, and if you have to leave, I understand, but I'd be happy to answer any questions electronically or any other way if you have to go.
I do see one question in the Q&A
Okay.
From a fellow volunteer, Dr. Kelly. How
Okay.
close are we to being able to customize treatments, specifically biologics, based on a patient's serologic, radiographic, genetic findings?
He asked if you can customize treatment.
How close are we to being able to customize
Well,
treatments?
we are getting closer. There actually is a move to actually personalize the treatment strategies, but none of those treatments that he mentioned, the biologics or the DMARDs or any of those are personalized. So there is some literature, and I'd be happy to send him some references about personalized, but boy, it's right on the cusp. It's something that we are just not there yet. That's a great question. I mean, I think ideally it'd be wonderful if you could know more detail about the patient's genetic makeup and more detail about the specifics of their disease. But right now, I think this illness is where probably rheumatoid arthritis was 20 years ago, 30 years ago, in terms of its understanding its physiology. And by the way, I have a prediction. I predict that as I said early on, the lumpers were in vogue, and now the splitters are in vogue. I bet one time in the next few years, if I give this talk again, which I'm sure I will, the lumpers will be back, because the evolution of the pathophysiology is just favoring lumping them all together by virtue of their many different features that I went over. All right, well, it's great talking to you again. I can't remember what I'm going to talk about next time. I've got one more lecture with you, and I can't look at you and see whether you've been involved with one of my lectures before, but I love the concept of talking to the same group about different things, because I know where you are in the spectrum of diagnosing and managing these patients. I never could have given you this lecture at the very beginning, and I think I've worked from the point of very simple rheumatology to something that I think is very complex and requires a lot of thoughtful consideration. All right, that's it.
Thank you so much, Dr. Upchurch. It was a great presentation, and thank you to everyone that attended today. Hope everybody
And everybody who attended, please fill out the questionnaire. I mean, you have to fill it out to get CME, but I want to know what I can do better. Okay, so tell me. Or if you think I'm great and the best thing since, as they say, motherhood and apple pie, you can tell me that too. But I really do want to hear from you about, or other topics you want to learn about, or anything like that. Okay.
The best. Somebody said you're the best thing since apple pie.
With ice cream on top. I'm the ice cream on top of the pie. Is that right?
Thank you for putting that out there, Dr. Upchurch. I did put that in the chat, a reminder about completing this survey, and we do really appreciate your feedback. So if everyone could please take that time. Well, in order to get your CMA, you have to, but we also appreciate the feedback, and we share it with all of our speakers. So thank you. Okay, well, everybody have a great rest of your day. Thank you so much.
Thanks, guys.